Hello, everyone. I'm Sheila Myatra, Professor of Anesthesiology and Intensive Care, working at the Tata Memorial Hospital in Mumbai, India. I'm also the President of the All India Difficult Airway Association. In addition, I am the Chair of the Intensive and Critical Care Medicine Committee of the World Federation of Society of Anesthesiologists. I'm going to be speaking to you about the PUMA project. What is PUMA? It's a project for the universal management of the airways. I'm going to be speaking about the PUMA guidelines, and I'm going to be covering the following aspects about the PUMA guidelines. Now, the concept for PUMA was born during the World Airway Management Meeting in 2015 in Dublin, where a group of international airway experts met and they discussed the need for having a universal approach towards airway management. Now, this is our PUMA working group. It comprises of 14 members, 11 are anesthesiologists, 3 of whom are intensivists, and 3 are emergency physicians. Professor Karen Hagberg from the United States serves as the chair of the committee, and Dr. Nicholas Crimes from Australia is the project lead. Now, recently in Anesthesia, Elderman et al., they published a review article on difficult airway management guidelines. If you look at the last 20 years, there has been an increase, a cumulative increase in the difficult airway guidelines that have been published by various organizations and societies. And this is a distribution of the various difficult airway guidelines that have been published. So we have 38 published guidelines, algorithms in the last 20 years, and still more and more coming up. The authors have expressed that there is lack of data on the implementation or the penetration of these guidelines and outcome of patients following the use of these guidelines. The authors have also alluded to the PUMA guidelines and expressed the need for a universally endorsed and recognized guideline for the management of airway. Now, during cardiac arrest, we perform chest compression irrespective of where you are, in which hospital you work, or which parts of the world you work in. There's a uniform way in which we provide chest compression. And this is because organizations like the International Liaison Committee on Resuscitation works with various other resuscitation associations in order to ensure that the principles of BLS and ACLS are followed universally across the globe. Just imagine if we had to give chest compression in different ways in different parts of the world. Well, this is exactly what is happening to difficult airway management. There are different difficult airway algorithms and approaches that are followed by different airway societies. What the PUMA project is trying to do is look at the commonalities between the guidelines, put them together, get them approved by a group of airway experts. The PUMA guidelines are not in any competition with any of the existing guidelines. In fact, it is looking at a universal approach, taking all the good points of the various airway management guidelines that exist. In other words, the PUMA project is about the application of the principles of cardiac arrest training and clinical practice to airway management. It's not that we have 100 guideline algorithms and we're making a 101st one. It's not just another difficult airway guideline. In fact, it is a unifying document. The PUMA guidelines look at the commonalities between the existing guidelines and review the common points by experts and then get various statements made in order to form the universal guidelines which can be used in all contexts. So the PUMA guidelines are independent of context, independent of geography, provider, location, patient, the indication for airway management, the urgency of airway management, the complexity of the situation, and also the intended airway. Now, if you look at the rationale for the PUMA guidelines, we have guidelines for adults, pregnant patients, trauma victims, and critically ill patients. Just imagine if you had an adult patient who's also pregnant and had a recent trauma and is now critically ill, which algorithm are you going to follow? Now, most of the difficult airway algorithms are made by anesthesiologists for anesthesiologists working in different settings. But airway management is practiced by intensivists, emergency physicians, paramedics, airway assistants. Now, which algorithm are they going to follow? In addition, the algorithms that are made by anesthesiologists need not necessarily be applicable to all the contexts. For example, for an intensivist, it may not be possible to wake up a critically ill patient. So these are various aspects that we need to think about when we're making universal guidelines. Most of the guidelines are intubation-centric, where the intended airway is a tracheal tube. But we know today that we may start with a supraglottic airway device or just use a mask. Now, whenever you have a crisis situation where you cannot intubate a patient and you also cannot ventilate, you reach a situation where you may need to perform neck rescue. There's still a debate as to who is the best person to do a neck rescue. Nevertheless, what's very important is to do it at the right time, and also make sure that you are trained in any technique to do it properly during a crisis situation. Now, I'm sure you've all heard of the Ellen Bromley case. This is one of the most famous cases on in difficult airway management situation. And it is a situation where lack of situational awareness, teamwork, and decision making led to a potentially salvageable airway deteriorate and result in poor outcomes for the patient. And what is interesting is even 15 years after this case, we still, very few algorithms are able to address this very situation where the intended airway was a supraglottic airway device. Cognitive efficiency and human factor considerations are extremely important. What the PUMA project has done is give human factor recommendations side by side along with the technical recommendations. Now, there are also countries without guidelines. So we cannot wait for all countries to have their own guidelines. We need a unifying guidelines. The various context-specific guidelines, obstetrics, pediatrics, intensive care, these guidelines are all excellent. What PUMA is trying to do is make a unifying guidelines that can be applicable to all these different contexts. When we have context specific guidelines, it results in siloing of ideas and divergent practices. What we need is universal principles. We need a platform for collaboration. We need a universal guideline that can be applicable to, independent of the context that of and the situation where we are working in. Then there are multiple terminologies that are used in the guidelines. Critical language is extremely important during difficult airway management, and there have been reviews published by Nicholas Grimes and Tim Cook. We recently wrote on critical language during an airway emergency and whether it's time to rethink the terminology. Now, critical language is that language that is used during a crisis. Critical language needs to be very simple, very clear, very specific, and universally understood. Now, the PUMA project did not try to make any new critical language. We used the existing language that was there in the various difficult airway guidelines from the various societies. And we only addressed this if we felt there was a disconnect between the terminologies that was commonly used in clinical practice versus those that were used were dominant in the literature, or we felt that the particular critical language may result in some unsafe practice. Otherwise, by and large, we did not address the critical language. The methods that we followed were quite simple. A major chunk of the work was done by our working group of 14 members, and these are from 4 different continents. We had a few face-to-face meetings, but largely we were working through video conferences every alternate Saturday for the last 5 years. We have been working on this. The first step was to take all the difficult airway guidelines, review them, do an extensive literature search. Based on these statements of common principles among the guidelines was formed. And then we made these statements into various surveys, which was answered by the different members on our working group using Likert scale rating. We also had free text where they could put their comments, which were later discussed. Whenever there were controversies, this was put to a 60-plus member advisory group that did not just consist of airway experts, but also other experts like human factor experts, etc., from 17 different countries. Now, PUMA is not just a rehash of the existing guidelines. There's a lot of novel content, and there's a lot of silent areas which have not been addressed by various difficult airway guidelines, which PUMA has taken up. Where are we today? So the universal principles that we have planned to make are for concept and methodology that we're using, for airway evaluation, airway strategy, what is about airway rescue, and also about communication of the airway outcomes. So far, we have published the concept and methodology paper last year in anesthesia, and we hope to publish the remaining 4 sections in the next few months. Following the publication of all the guidelines, which will be not only done in the anesthesia journal, but also in the critical care and the emergency medicine journals, we will have extensive training programs, not only face-to-face, but we will also have web-based training, and we'll have various educational resources that will be put out. So to summarize, PUMA is not just another difficult airway guideline. It is a unifying document. It's non-context specific, a unified approach to general airway management principles. PUMA has universal airway principles, and PUMA is independent of context, geography, provider, location, patient, indication, urgency, complexity, and even the type of intended airway. Now, whether having a universal approach to airway management actually improves outcomes or not needs to be further evaluated. I thank you very much for your attention on behalf of the PUMA working group. Thank you for a patient hearing.